Dorinna Ruh. I am an LCSW in Colorado. I live in Fort Collins. Sarah, who's to the right of me, is my, she's in my building and I know her quite well. She runs Hope Roots. And so we're teaming up together to present this, and then Hope Roots is going to take over the reins and then keep offering this training. So if you found it beneficial and you think other people you know could benefit, please let them know. I do a lot on Facebook where I'm like, assess for dissociation. I keep putting that in, and I thought maybe I should just do a free training and just start getting the message out a little bit clearer. So that's kind of how this idea, that's where it came from. So I've been a therapist, a counselor, I guess I should say, for 34 years, and I got my master's in 95, and I moved to Fort Collins and got talked into a private practice. And then from there, someone said, if you get EMDR trained, I'll refer to you. So back in 2001, purely to get business, I did not think EMDR was a thing. I just thought, what the heck, I'll do it. Cost me, you don't even want to know, $325 per weekend to get trained. Got my training, and I obviously bit the hook. So now I am pretty much an EMDR therapist. And along the way, became certified, approved consultant. I facilitate for HAP, which has been an incredible learning experience. And now my focus really is doing more consultation and training. I do have a private practice and I work with adults. And in addition to EMDR, I ended up studying with a woman named Joanne Twombly. You are going to see her name all over my slides. Joanne is an amazing human being. She taught me pretty much everything I know, I would say, or most of what I know about working with dissociation and EMDR and complex trauma. And she does have a book. It's going to be in the references that I sent to you. So, but her handouts are going to be all over this presentation, because she's also a very generous human being. So anytime I say to her, can I share blah, 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 she says yes. And so yeah, I studied with her for quite a while, and that was about 10 years ago. And ever since then, have really specialized in complex trauma. And that's why we're here. So why don't we get into the presentation? And as I said, if you have questions, either put them in the chat or just say, hey, Dorinna, and I'll pause things, okay? We are recording this and it will be online. So if you are someone who's a little uncomfortable with having your face, your little box this big, and your name, please do what you need to do to stay comfortable, so you can shut off your camera if you want to, and change your name. All right, so screen share. There we go, assessing dissociation. All right, so Sarah is going to talk a little bit about Hope Roots, because they are presenting, kind of hosting this for us. Do you want to just, are you okay, Sarah, talking with the slide on?
Yeah, that's fine.
Okay.
So yeah, I put the vision and mission statement here on the slide. On the green bits on the right are our guiding principles, but the keyword here is in our mission statement down at the bottom: to increase access to trauma-informed mental health services through training, partnerships, and trauma therapy. And so this definitely fits exactly within that. We want to increase access for clients, but also a big part of that is making sure that there are enough providers, enough providers getting the training they need to feel comfortable. And I was, Dorinna is definitely the one who trained me to assess for dissociation. And I was amazed at how much I learned from her, but also I think kind of sad and disappointed that there was so little, I think in a graduate program, to really understand things like this. And so I realized right away when I finished my counseling degree that there was a lot that I needed to know. And I would put this probably at the very top of the list of things that I was like, wow, this was really important to know. And it's disappointing that we don't all just get this, when we complete a graduate program to offer therapy. So I'm, really happy that we can offer this. And like Dorinna said before, the hope is to put this online for free. So we'll edit, some bits of it and get it out so that people can have it as a resource. So, thanks for coming. Thanks for signing up. Please stay in touch.
Okay. Well, thank you, Sarah. I probably should have had your little picture in the corner, but I didn't know how to do that. Okay, so let's move on to the discussion. All of you should have gotten a copy of the handouts. So really, the heart of this discussion is a misdiagnosed client is bound to be a mistreated client. And the numbers are pretty interesting. I don't know how many of you are familiar with the research. I'm not going to go through it really thoroughly because you can read. I put some information, some links in this presentation. But most people, if not all patients, who have experienced early relational, physical, or sexual trauma and neglect have dissociative symptoms. And I think something really important to notice, and I don't know if anyone caught it immediately, it says relational. It does not have to be some of the worst trauma that we think of for dissociation to be part of the package. When people do have untreated dissociative symptoms, I think we all know that it can slow, stop, and or complicate treatment. Now, these are the numbers that are the ones that if you don't know, you're probably going to be like, wow. There was a study. They looked at 7 other studies of 719 DID clients. And the average time that these people were in treatment before appropriately being diagnosed was 7 to almost 12 years. So think about that. Think about people in therapy, different therapists, the same therapist, who knows, for that long, and no one is treating their dissociative disorder. They probably don't get better. And the amazing thing is that 80% will get better if they have the right treatment. So finding this is so important. And believe it or not, I know we're all like, oh, DID and how scary it is. It's really, once you know how to do it and you understand what's happening, it's really not that hard. You just need the training. And I think people are starting to find that as they learn more about how to work with people with dissociation. I like this quote. We have to realize that when children are with frightening and abusive caregivers, they can't fight, they can't flee, and they are completely dependent. I said this to somebody yesterday, and I think I'm right. They have 2 choices. You're a little kid. The people who care for you, who keep you alive, are also abusive and scary. You can die or you can dissociate. And so I think we have to appreciate how necessary this is for folks with trauma, early trauma. Real quick, I'm not going to read all of this, but some of the newer numbers that came out, there's a really, I don't have the link didn't come on. There's a really great article in the EMDR journal, and I actually think it's available for everybody. It should be in the references, where Andrew Leeds, Michael Coy, and Jennifer Madera put together an article about the DES2, and some of these numbers were in there. And I'm sorry, there should be a reference, but basically that we're starting to think that the number of people in the general community who meet criteria for dissociative disorders is 11.3%. So dissociative disorder doesn't necessarily mean DID, but that they would have some sort of dissociative issue that's worth paying attention to. And as you start to narrow it down and you look at more of our clinical population, we start getting numbers like 29% of people meet criteria for a dissociative disorder in outpatient, 6% meet criteria for DID. So I think there tends to be this belief that, it's so rare, right? 1%. We're never going to see DID. And I think we need to realize that 6% is actually higher than we think in our clinics. And you can have, they don't call it DDNOS anymore. They changed it to two weird things, but you can have that and still need dissociation treatment, even if you don't have DID. So for me, it doesn't matter if you have DID or you have DDNOS or you have UDD or whatever they're calling them these days. I'm going to treat them all the same, actually. All right. Here's that link to that article, it's in the references. A third of people in outpatient might meet the criteria for a dissociative disorder. A third. So if you think about your caseload and you cut it in a third, that's how many people you might have who have dissociative issues. A new study's coming out, 10 to 11% of the population. People with gender dysphoria definitely have higher dissociation symptoms and a higher rate of any kind of dissociative disorder. And this one, I'm just going to summarize because you can read it on your own, but But part of what happens is people end up either A, they don't get diagnosed just because there's not enough education out there for people like us. B, they don't even know they have it. Like they have no clue they have a dissociative disorder at all. So they're sound like they're coming in and saying, oh, guess what? I dissociate. And then they usually present with some other kind of medical issue or a mental health issue. So they're coming in with PTSD, they're coming in with mood disorders and substance abuse and sleep disorders and everything else. And it's so easy to treat that. That becomes their main diagnosis. And the dissociative stuff sort of gets pushed aside or overlooked, I guess is a better word. All right, so I'm going to add a question to this that I thought I said this yesterday, and I was like, oh, this is great. So two ways I want you to start to rethink dissociation. Okay, someone is sitting in your office, they have a trauma history. I'm imagining most of you are trauma therapists because you're here. You are not going to ask, does the client dissociate? The question really is going to be, how much does this client dissociate? You're going to assume that they do. Just start there. And that brings me to my second line that I think is a really good one to keep in mind is I'm going to encourage you not to rule in dissociation, but rule it out. Which means, again, you assume if someone comes into your office with trauma from childhood, you're immediately assuming that they have dissociative issues of some kind. Then you decide where to go from there. And you might find that it's just a little kind, or you might find that we're way over on the other side of the spectrum, which I'll show you in a minute. But if you can just reframe your thinking, I think it's going to make things a lot easier for you. And I'll just be completely honest. When I first started my EMDR training, I got EMDR trained. I used to be a substance abuse counselor, and I was a substance abuse counselor in the 90s. And I don't think it's like this anymore, but the motto was no trauma work in the first year. That's what I was trained. So guess who knew nothing about trauma work? Me. And now I look back and I'm a bit horrified, but that's the way it was. I hope it's not like that anymore, but I'm no longer in that field. And so when I got trained in EMDR, I would give somebody the DS. Under 30, check, they're not dissociative. Over 30, check, maybe they are. And that's all I did. I did not know this either. And I learned sometimes the hard way. Fortunately, nothing really serious happened, but some scary things happened because I had missed things that I would have caught now. So I know what it's like to start at ground zero with this stuff. In some ways, I think I was behind ground zero because I literally was told not to do trauma work. So how do these people present? Some of them look very stable. You wouldn't even know. They have PhDs, they have successful jobs. There's no clue necessarily that they would have a dissociative issue. So you want to keep it that way. They can be very quickly and easily destabilized. You might find that these folks make superficial progress, but you really aren't getting to the underlying issues and healing the underlying trauma. And my guess is that's part of what happens to those folks who are in therapy for 7 years and never get diagnosed. And there are treatment techniques where you can actually protect the client's stability and make the treatment work and do trauma work. So I guess that's going to be part 2 potentially. So client presentation, they may look like everybody else. They usually will not present with a diagnosis of dissociation. Some of them know, and they're waiting for you to ask. Some of them have no idea. Most, I would say, come in with other diagnoses. And they may be leading chaotic lives, and they may not be. All right. Any questions so far? No? All right. Let's keep moving along then. I'm not going to spend a whole lot of time going into what the DSM says dissociation is. I am going to say this, though. So there are these 5 pieces we look for. We look for amnesia and time loss. We look for depersonalization. So that's feeling really detached from your body and who you are. We look for derealization, which is where you feel like you're detached from your environment. There can be identity confusion, although I would say that one's probably less seen outwardly. And sometimes then we're looking for identity alteration, where different parts of the mind have different jobs and different way of being. My experience is that most of my folks who actually have a DID diagnosis do not shift. They don't have flagrant parts, but they do have fragmented parts that will take over enough so that they are dissociated and then another part is functioning. But they're not necessarily like, this is Joe and this is Barbara and this is whatever. And they don't necessarily switch that dramatically. They mostly just go away. that can be present and it can be DID. The real hallmark of DID, just so you know, is the amnesia piece. I don't know if anyone's familiar with the book, The Haunted Self. It's a really good book about structural dissociation. It's hard to read, but it's a good book. It was one of the books that Jim Knight told me to read early on when I was fortunate enough to work with him, and it literally took me 10 years to read it. It's a little bit tough, but how they explain it is that, and I don't have drawings for this, but that we will have multiple emotional parts that hold our trauma. The EPs hold our trauma, and then their model is that there's the ANPs, the apparently normal parts that function, and that when we have simple trauma, we've got one ANP and maybe one EP. When we get into what they call secondary trauma, we've got one ANP functioning and lots of EPs holding trauma. With tertiary dissociation, and that's where we start to get into DID, there are more than one ANP functioning. So there might be one ANP who goes to work and maybe a different ANP who shows up and has sex with their partner. And so that's how more split the system is. And that's the way they describe it. So for what that's worth, I think that's kind of an interesting way to look at it. I think probably every single one of you knows this. Dissociation is on a continuum. All the way on the left would be most of us who don't have a dissociative issue, highway hypnosis, daydreaming, right? All of a sudden someone's talking to you and you're like, oh gosh. It happens to me in my office. I'll be sitting there and think, what am I going to have for lunch? And then all of a sudden, oh my gosh, like it doesn't happen a lot, but we can have our minds go other places. People who are athletes, soldiers, they do it a little bit more. They're in the zone. I know soldiers, I think some have told me they are trained to dissociate. And then you can really be in the zone. Then there's acute stress response. Then we move into PTSD. Now we're talking about a dissociative subtype of PTSD, which probably we would call complex PTSD. And then we get into the otherwise specified dissociative disorder, unspecified dissociative disorder, and then we've got DID at the end. In my opinion, once you get into there, you want to keep assessing. Because and I don't know if any of you have seen this in your office, there are some folks who dissociate all the time. They just live in dissociation. They're all the way on the right. There are some people, they just dissociate in your office when you talk about trauma. There are some people who only dissociate when you start doing EMDR on the worst trauma. It can unfold gradually, and you might not see it all from the very beginning. So once you hit PTSD, and again, just like I said, it's not are they dissociating, it's how much. You're always going to keep your little dissociative lens on or out, because it can happen. It recently happened to one of my consultees, where he had done just the best planning with this client. He had gotten lots of resourcing in place, had assessed for dissociation, really was ready to move forward with the MDR, and decided, let's start with the simpler targets, and then we'll move into the medium hard traumas, and then we'll head to the last, like we'll go in a order backwards from instead of first to or worse to less worse to, I don't know what's less worse. Anyway, hopefully you know what I'm saying, right? So they started with sort of the more easier, less intense traumas, did fantastic, no dissociation, got to the middle, and boom, dissociation started. So you just want to pay attention. You want to keep asking. I'm going to talk about that in a minute. Rob, do you want to ask a question?
Yeah, I had a quick question. Just I'm wondering with ENAs, like intrusive negative affects that can sometimes pop up, and I part of me feels as if it might be a part in the person that kind of, like as you were saying, that EPs might be throwing in a different emotion to kind of curtail what you're doing, and I'm wondering if that plays into a dissociative presentation at all.
So I honestly am not familiar with the term ENA. So you called it a intrusive
negative affect. So in there's other words for this. So some people say it's a defensive emotion or some like there might be another word for it too. I know in my AEDP training there's a statement like there's defenses, and then there's these emotions that kind of block or curtail the therapy, and you actually have to address the emotion.
I think unfortunately, I don't think I have an answer for that, because I think what you're talking about is a model that I don't like. So I tend to think of things in the structural dissociation frame, but mostly I think of things in internal family systems. So when someone has an emotion come up, I will oftentimes try to figure out what part that is. And then I turn it into parts language and work with the part.
And that's how I would see it too. So
Okay.
it is Ina's really come out of attachment based
Okay. Okay.
dialogue. So yeah. Okay.
I'm thinking this next slide might help answer that question, but we'll see. And if you feel like you want to try to explore that some more, we can actually, if we have time, we can talk more about it with the group, because attachment definitely plays a role in all of this on some level. Okay. Anybody else while we paused? Okay. Oh, so Joanne's name got cut off. Oops. Uh-oh. Nope. Nope. There we go. I'm trying to get me out of the way. Oh, that's not the way to do it. So I am a very visual person. So when I look at this makes complete sense to me. And I find that I have a really hard time explaining why, but I'm going to do my best. So this is a chart that is in Joanne Twombly's book, Trauma and Dissociation and Trauma-Informed Internal Family Systems is her book. And I really do not think it's an internal family systems book as much as it is a dissociation book. But this may apply a bit to what you were just asking, Robert, that on the left side here, they're calling them normal ego states. It's really the same thing as parts language for those of us or those of you who are familiar or use IFS language. I was with a very dear friend of mine over the weekend, and she's an EMDR trainer and all this, and she's immersing herself in ego states. And she said to me, you know, IFS stole everything that they do from ego states. And I was like, oh, really? And she says it's all the same. So parts, ego states, alters, I don't know. I think they probably are used kind of interchangeably. But that on the left side, you can see how the parts, they're just sort of kind of like shadow lines around them, which means there's like a blurring in between. So if I'm sitting in session and all of a sudden I get a little distracted and think, oh, I'm hungry, what am I going to eat? So maybe a part of me pops in and is hungry, and then the therapist part of me gets a little bit hijacked for a moment. There's enough blurring that I'm going to catch it and think, oh, not now, and I'll come back and be a therapist. We kind of blur back and forth pretty easily. Maybe we get triggered, we might get upset about something, but again, generally we're still us, we're still here, and we're usually able to understand I am being triggered by this, and now I'm feeling upset, and we're present to all of it. But as we move into more what they're calling ego state pathology, which becomes more dissociation, parts are not that blurred, if this is making sense. You can see how the lines get more and more discrete as you move to the right, which means if a part gets triggered, it could potentially either feel as if everything is happening right here and now, and there is no conscious really acknowledgement of, oh, I'm feeling triggered. It's like, holy crap, I am in the danger. And then as we get more to the right, parts are just so fragmented and separated that there is no connectivity. And it's very hard to access them. And that's where I think we find people switch like dramatically, where now they're this person, because there is no sharing of the duties. It is very much one at a time. So I hope this is making sense, because I find I have a hard time putting words to it. This is where I think one of the big places where dissociative disorders matter a lot when we get into EMDR is that once you get all the way to the right, there are probably going to be parts whose job is their job is, I have to keep the trauma memories away. And this happened to me where this client had a part whose entire job was to keep the memories away. And as we started to get into we did EMDR with like a recent trauma, and that was fine. And we were planning for a childhood trauma that she had less memory of. And again, that was a long time ago. Now I probably would have been more careful, but I clearly wasn't quite careful enough. And her part, she dissociated one day and crashed a car. And her belief was that her part did that so that to get her attention, because this part did not want these memories getting opened up. So a lot of the work that has to happen when we get into those kinds of systems is we've got to get everybody on board. Because if we start diving into a trauma and trauma work when there are these amazing protectors holding things in place, things could get really ugly in some sort of way. I would say best case scenario is just the person just shuts down and nothing happens. And then the worst case scenario is you are going to get some sort of aggressive part that's like, oh no. And so we want to avoid that. And plus we're unable clearly to get any kind of dual awareness if there's that kind of part takeover. So as we move into, let me go back here, if I can figure it out. Here we go. As we move back into this, that's part of what we're assessing is how fragmented are these parts, how much co-communication, how much connection, how much agreement, how much safety is there in the system, or do I just have a whole lot of parts stuck in trauma time? And do they need a little help feeling safe enough to do this work? That's part 2 of this conversation. But just to kind of give you a little bit of a framework, that's ultimately the goal, is to get connected with parts, help them to understand that they're seen, that things are safe now, that they're not caught in trauma time, and perhaps they don't have to do their job quite so big, and we can all work together to heal. So I hope this makes sense to folks. I'm going to move on, and if you have any questions, or actually, does anyone have any questions about this chart? Because I had gone over this with somebody who's in this training, and this is the updated one, so it's not as confusing. There was this old one from 1996, and it still had MPD on it. And Joanne luckily edited it or redid it, and now it's up to date. So, okay. I put this in here. I don't think we need to talk about it because you can read the DES. Or not the DS, the DSM, but really, we're really starting to see there's still going to be parts with some of these other specified dissociative disorders and UCC. We're still going to see parts, but maybe they're not quite dark black like that. Maybe they're just lighter black, but we're still going to have that parts issue, and we're still going to need them all on board. I think that for me it's just so key that we have to get everybody on board and everybody safe enough to move forward. And generally speaking, I think when we have someone who we have misdiagnosed or we haven't caught the dissociative disorder, and they end up having a really big struggle in between sessions, to me, that's a huge clue that there's part of this system that is not safe to move forward. And anytime that happens, that people really struggle in between EMDR sessions, we need to pause. We really do. I had someone come in years ago, and she had been doing EMDR therapy with another therapist. And she said, oh my God, it was awful. Every time, like, I'd have the worst weeks, then we come in, we do it more. I'd have another bad week. And I remember sitting there thinking, you have a dissociative disorder. And then wouldn't you know it, it took maybe about a month. The next thing you know, something triggered her, and she was literally laying in the floor in the fetal position at her house. And I was like, yep, there's like that. Now I have more evidence, but I knew it just from that symptom alone. So really pay attention to that. If someone is really struggling, there's a really good chance a part of them is not ready to do this work. And they are not processing. There's not going from the adaptive to the maladaptive to the adaptive. They are just reliving. And that is not a good place for them to be. So that's another part with that fragmentation, is they are stuck in trauma time. Don't know why that keeps doing. Okay. All right, I'm going to go over this really briefly. I think when I do this as a big training, I think we're going to actually do it as a practicum, but this is something you can consider and think about on your own. These are the criteria for PTSD based on the DSM. So we're talking actual or threatened death, serious injury, sexual violence, either experiencing it, witnessing it, hearing about it of someone that you care about, but or maybe like a first responder where you see the fallout of it. But it literally says actual or threatened death. And so I think part of what that sets us up for is it makes our PTSD diagnosis criteria kind of narrow. And if you remember back to that first slide, it literally said, just if you have relational, sexual, physical trauma in an early age, you probably have a dissociative disorder. Relational trauma does not quite fit PTSD. And so what I'm going to share next, that I'm going to have you kind of look over on your, so let me share this slide, and then there's going to be a whole bunch that you can review carefully on your own. What we're missing in that is psychological maltreatment, neglect, separation from caregivers, parental mental illness, inappropriate sexual behavior, parental substance abuse. One of the things that I would add is even just teasing and bullying by peers. One of my people years ago I worked with, that was his trauma. He was a different kind of kid. He had been teased always. Now he's an adult and he's just socially anxious. He's got trauma. And I remember bringing this case to Joanne Twombly, and she's like, Dorinna, he dissociates. And I'm like, no, right? He can't dissociate. Well, we start talking about it. He would spend hours in his closet, I think it was, and just zoned out. And this is a person that did not have, as far as I ever could find out, any kind of physical or sexual trauma. It was all relational. So we need to remember that all of these things, that the ACEs things, they're all trauma. They don't have to be the worst trauma to count for PTSD. So this is a quote there's a book about the brain by Ruth Lanius, and I don't remember Freeman's name, but this quote I think is kind of reinforces that the disposition toward normal remembering versus dissociative re-experiencing of traumatic memories cannot simply be predicted by the severity of the traumatic event itself. So again, that's their quote from their book about the brain and trauma, and it's quite an interesting read. Actually, it's more about the research in the brain, and it's in the references. I cannot remember the name of it offhand. So this is the big chart that someone Sarah Hui put together. It's just a really great thing to read through. But really what it shows is here's what PTSD kind of on the left looks like, and the stressors that cause it. Here's what complex trauma stressors are. And so clearly it begins in childhood, lots of repeated exposure, disruptions in caregiving. I don't know why this is, okay, oops. And then as we keep going, the things in black are the things that are different for complex trauma in terms of the symptomology. So lots more of the symptomology shows up with complex trauma than in PTSD. And those are things you can keep an eye out for, because again, if these are things that show up in complex trauma and they're not in our PTSD diagnosis, it's more likely we're going to miss them. But there's a lot of them. I mean, so again, hopefully you're kind of reading them over a little bit here. But keep this as a reference, because this will help you potentially find your dissociative folks that are hiding. Again, we've got more. Look at all the somatic ones, and look at how this list. I think the PTSD list stops here, and the somatic one just keeps going, or the complex trauma keeps going on. We've got attachment, we've got distrust in relationships, difficulties with intimacy. Lots of empathic hypoarousal. It just keeps going. And these two are going to come up again. Multiple failed treatment attempts and hospitalizations are going to be a clue that someone has a dissociative disorder. And you'll see that again in a minute. In fact, you'll see it right now. So is this?
Hey, Dorinna.
Yeah.
There was a question in the chat about assessing chronic migraines, whether or not those are dissociation. So as you mentioned the somatic symptoms there on that slide, I thought that might be a good place to pop that question in.
Well, the timing is really impeccable because it's also on this list.
Oh, there we go.
So this list is not showing up correctly. I'm kind of curious what happened here. Yeah, it's really long. I clearly have a slide issue here. I'm going to do this. I'm going to make, that's not what I wanted to do. Oh boy. How do I get everybody back? I'm sorry. My plan was to, speaker. That's not what I want to do either. I'm sorry. I am not. What I want to do is push this way over here. And okay, I stopped sharing right now, right? So I'm going to go back to screen share here. Okay, there we go. It's not as complicated. So I did not realize that this slide was a problem, but clearly it's a problem. I think what I'm going to have to do, and Sarah, maybe can you help me remember to do this? I have this as a handout, and we can send it to you as a handout. This is going to be really important, in my opinion, for your future diagnostic endeavors here. So what I put together is a list, and it comes from Richard Kluft, van der Kolk, and Twombly, and it is a huge list of signs that someone has a dissociative disorder. And obviously it's so big it didn't make it onto my screen. I apologize for that. It was there when I first reviewed this. The ones in bold are the ones that you can catch pretty darn early on, right? So if you say to me, tell me how was your childhood? And they say, I don't remember my childhood. There's a flag. It's mentally ill parents. Bing, there's a flag. Prior treatment failure, right? So someone comes in and says, I've been in treatment for 7 years. I've never gotten better. Like, I just think you can practically know at that point, okay, this person probably has a dissociative disorder, because the odds are it was missed. Lots of hospitalizations. Again, there's more instability, and perhaps there have been more hospitalizations. 3 or more prior diagnoses. Because again, one person's going to say borderline, one person's going to say bipolar, another person's going to say, gosh, who knows what. Well, what is it? It's actually complex trauma. Concurrent psychiatric and somatic symptoms. So especially those folks who have those physiological symptoms that really don't get diagnosed well. Severe headaches. So there's where the migraine things comes in. If someone has severe headaches and pain syndromes, again, does it mean you have a dissociative disorder? No, but it is a sign. So the way I see this is that you really want to look at this list and figure out how many a person has. If they have 1, and it looks like they had a pretty decent childhood and they're not reporting trauma and they're functioning fairly well and their doctor thinks they have a migraine disorder, okay, maybe there's fewer signs that this is a dissociative issue. But if someone comes in and they have a lot of these, you really just are going to go with, okay, I bet there's dissociation here. Now I have to figure out how big. So another one that's interesting is they easily learn coping skills in session and they fail to use them outside of session. So then there's this just huge list. It's almost a little too big, but I think it's worth being familiar with. So you could really, even if you wanted to make it a checklist, but it's going to be important to keep these things in mind. Because I think if someone comes in and they've got 4 or 5 of these bolded ones, you just know. You don't need more proof, I think, that there's something going on that puts them on the right side of that continuum. And now you got to figure out how to proceed.
Dorinna, I noticed when I asked about ENA's, I noticed impaired affect regulation, and I think that fits with what I'm referring to there.
Referring to, yes. Yeah. Yeah, so I'm gonna, let's see, I'm not gonna, I'm pretty sure these didn't translate well on your handouts, and I apologize for that. It was kind of squished onto one slide. We will get you a copy of this because I do think it's helpful. And the other one I'm gonna highlight here, one of them is, there's something in here about having a traumatic medical history. Kids were not treated well back in the day. Even in the past 10 years, they weren't. Kids were not treated well in their medical stuff. And so if someone has a young trauma or medical history, you might really want to consider looking a little closer at dissociation. My nieces are seniors in high school right now, and when they were 6 months old, they're twins, their heads were fusing too quickly, and they had to have surgery. It was pretty awful. They would only give them Tylenol, I think. Tylenol or ibuprofen. These little babies they did not give them any painkillers. And I just remember thinking how horrible that was. I've got clients who are my age and just they're alone in the hospital. There's no parents, there's no comfort. So keep that one in mind as something that's could be a really big problem for kiddos. And then also the idea that the therapist feels floaty. So sometimes we will pick up the energy of the dissociative person and we will take it on a little. We'll feel sleepy, we'll feel tired. So we really want to pay attention to that as well. So let me go back here to get back into PowerPoint. I'm going to talk about these briefly. So a lot of times we get those of you who are EMDR therapists get taught to DES. The DES, it's a screening tool, but that number means very little in a lot of ways. And so really what I see the DES is a way to get the conversation going. If you get a very high score, then that's information. If you get a very low score and somebody has like 5 of the things on that list, that the beginning part, don't take this as seriously as the number. Don't just, it's not that It's just a screening tool. It's not that accurate. I have never used the Niechenhaus one, but I do use the MID a lot. And so the MID is about 218 questions and it's really easy to access. There's a link in the references. There's a manual that goes with it. There's a 3-hour class and a 6-hour class that are taught. Michael Coy, who really heads up a lot of the MID stuff, super available for questions, super fantastic person. So the DES is a great way to get the conversation started. I think you want to read it to your clients. You want to pay attention to how they answer. Are they like 0, 0, 0, 0? Or are they thinking a lot? You know, is there like dialogue going in their head as their parts argue about what to say? How they take it is almost probably more important than the score. And then if you're still unsure and you haven't gotten enough evidence, then the MID, I think, is a really good one. The other ones are really meant more for diagnostics. And I think they're like super long, like 2.5 hours or more. You probably need a little more training to do them. I personally don't think it matters. So this is my philosophy. People may disagree with me, but once somebody is in that later section of a dissociative issue, I am going to treat them the same. I'm going to want to make sure that all their parts are on board, whether they have DID, whether they have DIDNOS, whether they have complex trauma. I'm going to be equally careful with all of them. So for me personally, it doesn't matter that much. I'm sure a whole lot of people would disagree with me. But once I know that there's that much kind of separation in the system with dissociation, I'm going to proceed the same way. So tips on, I think I said most of this. And we're going to talk more about this in a moment. But I think the important thing about the DS is to do it in person. Okay, there's the link for the MID. The little 3-hour class is on EMDR on demand through EMDR on demand. I took the 3-hour class and it very much is, here's how to use the MID with EMDR. The handouts are so detailed that it's a really good use of, it's a really good use of time, I think, that 3-hour training. I aspire to take the 6-hour and I just haven't yet. So just a couple of things. Again, I highlighted, here's the similarities between bipolar disorder and PTSD, all the symptoms in black. You're going to see that misdiagnosed a lot, particularly because I think a lot of mood stabilizers really do work for PTSD. You're going to see substance abuse really show up, I think, a lot, and it's going to be complex trauma. And here's a quote, it's just a quote from Van der Kolk saying, you know, we will do anything for these painful memories to go away. And substances and self-harm are a really effective, maybe maladaptive, but effective way to do it. You're going to see borderline personality disorder, and people are going to get diagnosed with that. And most likely they have complex trauma or DID. I question that diagnosis because I think what we do is we label people with this and then we forget that really what they are people with very, very complex trauma. I'm going to share this case and because this was one of my I'll be honest, it's sort of one of my embarrassments. And it's also part of the reason that I'm doing this is if you can avoid this, that would be fantastic. So I had a client come to me. She had one of the worst trauma histories I've ever seen. Poverty, dad died young when she was like 5, abuse from dad before, and he was a drinker before he died, abuse by mom, abuse by the brothers, sexual abuse, just on and on, then abusive partners. So there really wasn't a time in this woman's life, I think, where she wasn't in some sort of relational, sexual, physical abuse. Right now, if she walked into my door, I would immediately know she had a dissociative disorder. Because again, it's not, do you dissociate? It's how much. And with a case like this, what other choice did she have? Dissociation is a superpower that keeps you alive. And it's not a bad thing. It's just something you do early on to survive. And then unfortunately, people carry it with them when it's not necessary anymore. So she comes in, horrible history, bipolar diagnosis. She's been in the hospital a ton, lots of unhelpful treatment. I mean, she had to me like all the clues. And I didn't know. I kept moving forward with her. I did give her the DES. Anybody want to guess what she scored on it? Just yell out numbers if you want to.
25.
25. Okay. It was lower. She scored a 2. She scored a 2 on the DES. So we're moving along. We're doing EMDR. Things are okay. And then she comes in to see me on a Tuesday. This was years in. She comes in to see me on a Tuesday. She's doing great. So of course I'm like, good for you. Great job, right? Miss Cheerleader here. 2 days later, she eats, I don't know, 80 pills and almost dies. That's where I guess maybe I'd had enough education and something snapped in my head. And I thought, there's something going on here that I missed. And so we started doing parts work at that time. And I knew that somebody, I mean, for her to be doing that well on a Tuesday and then boom, you're going to die. There was a part thing going on there. And then it took a few months later and she came in for a crisis appointment and she was 2. And at that point she was sucking on her fingers. Who am I asked her, and she says, I know you're that nice lady that Tammy talks to. And she definitely at that point, then I knew, okay, oh my gosh, you have DID, and I've missed it all this time. So I was lucky because nothing really bad happened to her. Once I told her, and I said, we finally were like, hey, this is what's going on with you. I think you have a dissociative identity disorder. She did a ton of research and she was so relieved. She was like, oh my gosh, this makes so much sense to me. And what she figured out was that a part named Erica came into therapy to look good. And she scored a 2 on the DES because she was fine. And then she had all these other parts. And she was one of the people who actually people did come up to her and call her a different name and she didn't know why. So I just, again, it's just easy to miss it if you don't look for the right things. I would have caught this. I recently had, like within the past year, somebody called me just as an intake and I happened to answer the phone and she was hysterical and I can't find a therapist and I've never had good therapy. And I knew right there that she had complex trauma and dissociation just from that phone call. So just lean into the idea that it's probably there and then rule it out. That's, I think you're just going to be a lot safer that way. I think that, back of the head scale. All right. Some of you probably know this. How are we doing on time? I'm just going to share this because I think this, if you taught this to every single person who came through your office, it would probably save you, it would probably speed up the assessment or at least the conversation. So for those of you who know the back of the head scale, great. If not, this is a technique Jim Knipe came up with. And what it is a super simple way to assess where somebody is on the dissociative spectrum. So basically Jim will say, and now I say, and for those of you, Jim Knipe, it's KNIPE. He's written a lot about dissociation and EMDR, and he's got a book called EMDR Toolbox, which is fantastic. And he's also just a fantastic human. So you say to your client, let's imagine you have a line that goes from about here, and maybe I'll just show you this and we'll be done, I think that's it for the PowerPoint. Oh, almost. All right, I'm going to stop for a second and just teach you this so you can actually see me. So basically what you say to your client is you say, imagine there's a line that goes from about here to here. So it goes from here to the back of your head. And when you are here, you are fully here with me in this room. So like right now I'm chilly, I'm present, I'm feeling cold, I'm aware of the time, I know what day it is, and I'm here. But as we move back, we get less and less here. So I think this maybe is like, what am I having for lunch? Oh, not quite here, right? But it also can be starting to get so sucked into a memory or a feeling that it feels as if it's happening. And then there can be back here where you were in it. You were in the memory, you were feeling what happened. It might feel like it's happening. You might be on the ceiling or you just might not be present. So some people just get foggy and they just start to fade. The nice thing about this, if you teach it to everybody and say, once in a while, I'm just going to ask where you are. You can ask this all the time. And I do. Hey, just for the heck of it, where are you in the back of the head scale? And the beauty of it is the client only has to point. They do not have to say anything. And I don't know how many of you are aware of that. When someone is in trauma, Broca's center, which is our speech center, goes offline. So we literally are scared speechless when we are in trauma situations. So all I have to do is point, and you can just keep asking. You can notice, that person's eyes shifted. Hey, where are you? Just out of curiosity, where are you in the back of the head scale? And that's a way just to get that dialogue going. And you're just assessing kind of regularly. And if they're always here, That's super good information. Okay. So I'm offering you this as something you can use I think with just about everybody. And it's a great way to get the conversation going. People are not going to tell you that they dissociate. You have to ask them. So there's more information about the back of the head scale. Let's see, really, I'll just see, I would like to have time for questions. So this is my metaphor for working with complex trauma. So basically you're hiking along, you come to a lake and you think, maybe not this lake, but you come to a lake and you think, wow, that lake looks really fun. I would love to dive right in. I would love to go swimming. Look at, there's a cliff there. We don't just dive into the lake. Normally what we do is we wade a little bit at a time and we decide if it's safe enough to swim in. That's how I see ourselves working with people with dissociation. So we're at the lake, we're not diving in. We're going to step in a little bit. Oh, how are we doing? Our toes are wet. Okay, well, this person's doing okay. They're present and back of the head scale. They're tolerating things. They're doing okay in between sessions. Let's move forward a little more. Okay, they're doing pretty well. Let's move. And now we're up to our ankles. Now I'm seeing a little bit of a harder time. Now I'm going to back up a little bit. And I think that part of it is just being willing to use all of these little moves forward as clues. And so you're never just jumping in. You're always being careful to go piece by piece, assess, and then back up when you need to. So things to consider. Is this a complex trauma case? How many signs of a dissociative disorder are present? Again, you now have a list. What is the DS score and what info did I get when I administered it? I'm checking in with the back of the head scale and I'm moving forward. And as long as the client is tolerating interventions, and if not, I'm going to go back now, and you're going to keep assessing. So that's my sort of summary of this. Now, if someone comes in like my client and you're like, oh my gosh, I know you have a dissociative disorder and you're clear about it. So these steps are more for people that you're kind of a little unsure where they are in the spectrum. For people are on that right side of the spectrum, please get consultation, because there are really wonderful ways to work with them, but it's not going to be your standard way of working with people. Okay, so this is it for the folks that you're like, not really sure where you are yet. I'm just going to keep assessing. These are some suggestions. And the big motto in the dissociative disorder field is slow is fast. In treatment, slow is fast. All right. I am going to stop sharing the PowerPoint and see if in this last few minutes, if anyone has any questions. And let's get the whole big thing back. Oh, I know. I have to remove my pin. Uh-oh, sorry, Robert. Now you're pinned. Help me. There we go. No, not doing a very good job.
Blakely had asked about more trainings for dissociation, especially with EMDR.
Yes. How do I get the whole screen back? Does anybody know? Oh, gallery. There we go. I did it. Okay. I'm sorry. I don't quite do this enough to be a master at it. So Blakely asked about trainings. So I am doing a 2-day training July or January. I think it's the 26th and 27th. It's a Friday and a Saturday. And it's going to be this information expanded plus, so it's really going to be phase 1 and phase 2. Some of it will be repetitive. Let me think, other people who work with this kind of issue. So Sandra Paulson has a book called When There Are No Words. Dolores Mosquera does a lot with dissociation and EMDR. I love Joanne Twombly's model, which really it's incorporating parts where I use an IFS lens, but it just makes sense to me. Kathleen Martin is another woman who does a lot with dissociation. So Joanne is IFS lens. Kathleen Martin is more structural dissociation, but they both have similar approaches with working with parts. She does training. I'm trying to think who else. Jamie Marich. In fact, I just saw something on Facebook like yesterday. She's going to be doing a training on dissociation. People speak highly of her. So there are quite a number of EMDR practitioners who teach on working with dissociation and EMDR. Robin Shapiro does stuff with ego states, and it sounds like her stuff's pretty good. I know people who have taken her classes. I do consultation with them, and they come to me for consultation. They're pretty sharp. So I think she's teaching some good stuff too. So there are quite a few people out there. I would say the book I would recommend you get is Coping with Trauma-Related Dissociation. It is a workbook. And if I get really stuck with somebody and overwhelmed, we literally start reading the book together. And I don't do it often, but every once in a while I do. And it's a workbook. And so sometimes clients will buy it. They'll go through it. It is by Boone, Steele, and Vander Hart. And they also wrote The Haunted Self. And they also have a book called Coping with Trauma-Related Dissociation. It's called Treating Trauma-Related Dissociation. Those are good resources too. And then Joanne's book, I think, is just easy to read, easy to understand. I love her model. And that's available. I think that one's like $25 on Amazon. They're all available on Amazon. So did I leave any books out, Sarah, that you've read that?
Did you say Healing the Fragmented Hearts of Trauma Survivors? Is that the name?
I did not say that one because I don't think I know that one. Yeah, and if anyone else has any book recommendations, please put them in the chat.
I need to make sure I get the name right.
Were there any other questions before we run out of time?
You did mention Jim Knight's book as well.
Thank you. Yes. Yeah. There's a lot in that book about working with dissociation. And Jim, I would say Jim, the one thing about Jim is he finds ways to incorporate EMDR and probably a little quicker than some of these other models. Jim Knight's fantastic. So that's the EMDR toolbox.
Speaking of that, are there any for working with kids in dissociation?
I think that, so I don't know if she's an EMDR therapist, but the name that I hear a lot is Fran Waters. She definitely is a specialist. She works with children in dissociation. Someone in my town studies with her and works with her. I don't know about like Anna Gomez. I would imagine she must have some experience with dissociation because she's all over the kid EMDR world, but Frances Waters. Does anyone else know of any kid people who are working with dissociation?
I don't know. I bet the ISSTD would also be a resource to find
great
training, but also people who have more very specific specialties. Because I know they have subgroups. Because I'm in the EMDR one, they have like subgroups in the
They also
society.
do book clubs. That's how I've read some of these really hard books, is through book clubs with ISSTD. So it stands for the International Society for the Study of Trauma and Dissociation. And they do dissociation focused EMDR teaching, like they're teaching the standard protocol with an EMDR lens. And they have tons of classes. I just did a little class a few weeks ago with Bethany Brand and Frank Putnam. And it was just really an interesting $30. So you can join ISSTD and there's a ton. Thank you for mentioning that, Sarah. There's a ton there. And like Michael Coy is super, super involved with ISSTD, and he's also an EMDR practitioner. Same with Jennifer Madera. So we're getting more and more EMDR kind of focused things in that, in their, through their organization. They also teach like part one, like the friend I spent the weekend with is doing a deep dive into dissociation. She's a kid therapist, and she's really like, I need to learn how to work with dissociation. I guess there are level classes you can take where you literally, like, they go through all the books. And so there are classes about how to work with dissociation and how to understand it through the ISSTD. Yeah. So there's a lot out there. There are a lot of models, I would say. And that's the part where I don't know how to think about this without EMDR.
The reason I liked the Janina Fisher book, Healing the Fragmented Selves of Trauma Survivors, is at the beginning of the book, she kind of gives an overview of those different models. So she explains the difference between like IFS and structural dissociation and these different frameworks for understanding it. And kind of through different modalities too. She's like, if you were using, like, she talks about how different frameworks or different modalities would look at this issue and treat it differently, as kind of an introduction at the beginning to kind of like, let's get on the same page and then So that was really helpful for me
All
because
right.
when I read it, I was trying to figure out if I was going to do IFS training or not. And reading that really, really helped me kind of sort out what framework I wanted to.
Thank you. It sounds like something I should look into more. So one last thing before I know some people left. If anyone's interested in supporting Sarah's organization, they do accept donations. Our information is all in the back of the end of the PowerPoint. References are there too. I'm pretty sure all our contact information. So if you do end up with any questions, just reach out. My mission before I retire, which is going to be sooner than later, is to see how many people I can educate about assessing and treating dissociation, because it's just so important. And it's just, honestly, once you know how to do it, it's just not that hard, believe it or not. I know it's daunting as heck when you don't know how to treat it, but once you know what you're doing, it really it makes sense. And so, yeah, there's a lot out there to learn. And thank you. Thank you for coming. I don't know, Sarah, do you want to add anything?
That's great. Thank you so much for coming. I'll send out an email again with the handout we talked about. It'll probably be a few days, but I'll send out the things that we talked about.
That's fantastic. Thank you. Thank you all for coming. I appreciate it.